All right, we're about ready to get started with our next panel. This is the Reforming Employer-Based and Self-Insured Health Insurance in Alaska panel. I am going to let our panelists introduce themselves. I'll do the same trick I've been doing in most of my panels and say, tell us two challenges you're looking at in this area, something that you really want to address, and one opportunity or thing you're excited about. Also would be interested to hear, as you're doing your introduction, what have you heard to date that's exciting? You're one of the last panels, so what have you heard? What are you excited about? I'll start with Heather.
My name is Heather Carpenter. I am the acting director of the Division of Insurance since July 16th, filling the big shoes left behind by former director Lori Wing-Heyer. Lots of healthcare policy experience in Alaska. I like to say we just changed seats on the bus. So I've spent 4.5 years at Department of Health and Social Services, prior to that as a legislative staffer. Just as a reminder, when you're thinking about the Division of Insurance, we are 15% of the healthcare market. I think that's important to add in the introductory remarks. And we have the individual market, small group, and large group. Two challenges, absolutely the ending of the enhanced tax credits that are coming at the end of this calendar year. And I would say uncertainty. Uncertainty at the federal level and the state level. We don't know what's going to happen at either level. We've talked about the federal uncertainty. When I'm talking about state uncertainty, we don't know what state legislators want to do next, policy-wise. And they like to tinker in Title 21 because usually there's no fiscal notes. But that doesn't mean there's not a cost. Opportunity. With all of this uncertainty and what you heard Deputy Commissioner Ricci talk about, the Rural Healthcare Transformation Fund, we have a chance to align payers and policymakers and everybody in this room to do something really big and finally do something different. And that really excites me. So I think those are the things I'm excited about that we heard today. Even with the frustration, there's a lot of optimism.
Hi, good afternoon, everyone. Gary Stranagan. I'm with Premera Blue Cross Blue Shield of Alaska. In short, a little bit about Premera. We're a not-for-profit health insurance company. We are based in Seattle. We do business only here in Alaska and in Washington State. We're part of the BCBSA, the Blue Cross Blue Shield Association of America, and one of 33 plans nationally. We're a mission-driven organization. Our mission, if you will, is to make healthcare work better by placing the customer at the center of everything we do. And so that's Premera. About me, I have done a wide variety of things, not as wide as this guy, though. You'll have to get him later to get his full bio. But I started out as an aircraft accident investigator. Went from that into the state senate in Washington, and where I fell in love with public policy and the public policy making process. And when the voters later reconsidered their previous decision and they invited me to no longer serve them, and it was friendly in both cases, and we're grateful for it. But I got into think tanks. I did economic think tanks, and into insurance eventually, property and casualty insurance for a long time, where I invented an insurance underwriting patent. And then I was invited to come join Premera, and I'm looking around, I'm like, there's no underwriting going on around here. It's very, very different, of course, and it is going on, but nothing like P&C, as Heather can attest. So anyway, that's my journey. I'm newer to health policy than a lot of folks in this room, but deeply engaged, and I know a tiny bit about just about everything with respect to health policy.
Hello, my name is Pat Shire, a lifelong Alaskan. Years and years ago, I used to sell health insurance to small businesses and individuals. And for learning the vocabulary, I was assigned to the gulag of labor management health committees when I first went to work for the state of Alaska as an auditor back in 1988. And for those sins, I was ultimately assigned as the division director of retirement and benefits, and got a good look at the management side, talking to the folks here at the table in whatever capacities they may have been in, or whoever was in those roles, and became steeped in what I will call healthcare finance conversations. Wages or healthcare. Those are the conversations that happen at collective bargaining tables and at employee-employer tables all over the world, really, but particularly all over Alaska and in the United States, where we don't have national health care. When I was ready to leave public service, Fred Brown, who was the executive director of the Pacific Health Coalition, asked me if I would join the organization as the second employee, representing 110,000 belly buttons in the state of Alaska, who had banded together because they were tired of paying multiples of Seattle rates for healthcare services that, while they may have been high quality or at least adequate quality, those 5 times Seattle rates were just unsustainable in their mind, and they were losing more and more and more of their buying power. So it was the Teamsters, the electricians, the sheet metal workers, and the laborers who decided, for the purposes of negotiation, we will combine all of our numbers and assign you, Fred Brown, to go out and negotiate discounts that will benefit all of us, and yet we will retain our unique identity as the Laborers Trust, the Teamsters Trust, etc. And that really was the start of the Pacific Health Coalition that is now operating not only in Alaska, but in the Pacific Northwest, including Washington, Oregon, some in California have just been added, Nevada, and even some in Colorado. So we are interested in providing the highest quality possible health care at the best possible price for our members, not only in Alaska, but those that are now joining us and are even greater in number in other locations.
Thank you all. All right, starting off with our questions. Healthcare costs and insurance costs, they're consistently higher in Alaska than in other states. Why? What is the biggest driver of those costs, do you think? I'll start with you, Pat.
Thanks a lot. I can't see any of the incoming, so now's your chance. That's a great question that I wish I had the answer to, and I ask it whenever I have an opportunity. In the past, in just some history, I grew up in Fairbanks, Alaska, the son of a small grocery store owner where all the goods came in over the road from Seattle or Tacoma. And we knew acutely that the cost of the goods on the shelf were the result of freight and the high cost of energy, electricity, fuel to keep the store warm during the 50 below winters. Those differences have diminished over time, and now we find that the cost of living in Seattle is 6% higher than it is here in Anchorage. The cost of real estate in downtown Seattle, where practitioners may have their practices, is no longer below what it was in Alaska. So based on my accounting background and having been an auditor and looked at books for different businesses across Alaska, I believe buried in those operational expenses is part of the answer for why it's more expensive. A panelist earlier admitted that doctors do expect to be paid more to come to Alaska, and there are reasons for that, because it's away from friends and family. How many people in the room were born and raised here in Alaska? Okay, how many have family here? When I was working for the state of Alaska, we not only interviewed the person to fill the position, but we would want to talk to her husband to make sure that he would stay here once she took the job in Juneau. You know, there's that challenge. If Papa ain't happy, ain't nobody happy. You may have heard that before. But I don't have a clear answer for you. I think it's a question that is well asked and must be answered.
Gary, go ahead. Why do you think the costs are so much higher here?
I don't have a complete answer either. I do have, I think, a theory about what might have driven a lot of it, though, and that is the 80th percentile that was put in place in 2004 set Alaska on a different trajectory. It created an incentive for out-of-network providers to stay out of network, not join insurance company networks, and charge more. And it allowed them a lot of flexibility with respect to the rates that they would charge. And over time, the delta between healthcare inflation in Alaska versus the outside just grew and grew and grew. And so now you see, it's common for services to be 5 times more expensive here in Alaska than they are in Washington. And we can just fill reams and reams of books with data on every service under the sun, every CPT code. This is what it averages in-network in Alaska, out-of-network in Alaska versus in-network in Washington and out-of-network in Washington. So the repeal of that, which was led by the Division of Insurance, I think was really important to helping reverse that trend. Now, just like it built over time, the problem, I think resolving the pressures created by that problem will happen over time. And so we've seen our last 3 insurance filings here in Alaska for the individual insurance product. We've seen downward pressures associated with the repeal of the 80th percentile in those filings. And this year, I think they're public now, aren't they? Are they? I don't think so. Okay, well, so I won't give you a number, but it's even with the baseline healthcare inflation, which is still real, utilization is up, and the unit cost of services is up. So that's still effective, but we are seeing some downward pressure from the repeal of the 80th, and so we'll be, I think at the end of the day, you'll see a modest reduction in individual rates and a still larger reduction in small group. But I think it's important to note the backdrop of that. And I'm rambling a little longer than you're getting your money's worth here, folks. In Washington State, yesterday it was announced that the average individual insurance carrier in Washington State their increase was 21%. And this is common across the USA, except here in Alaska. And so I think the repeal is really bearing some fruit.
I'll build off of those comments, and while Gary is correct, we are better positioned in Alaska with what our rates are going to be. For the individual market, we are still the 4th highest in the nation. So we have more work to do. We're the only state that doesn't have managed care. We changed some laws in our omnibus insurance bill this year to hopefully make that an option for people. Is that the right call? Is it not? Those are, policy questions. We have done a lot of work at this. In 2017, going into 2017, Primera was going to be the only remaining insurer in the individual market. Director Wing Hire worked with former Representative Kurt Olson in the governor's office and got through legislation to allow us to apply for a 1332 waiver, that we were the first reinsurance waiver in the country, and that really stabilized rates. To date, we have received over $800 million of federal money. We have consistently increased our program amount. This year it was $140 million. Every year, and our waiver is condition-based. Every year, the claims that are seated exceed that program amount. That also tells me we have a bit of an unhealthy population with chronic conditions. Just like Medicaid has multiple chronic conditions and we can learn from their reports, we have the same problem in our market. And until we address those chronic conditions and help people get on that path to, finding a primary care doctor, making sure they have mental health care, all of those things, we can only throw so much money at it, and we're throwing all kinds of money at it, and we're still seeing increases. So I will say I'm relieved that I'm not in the same boat as the insurance commissioners in other states this year, but that's on the back end of multiple years of high increases.
All right, I'm going to start with Heather this time. You mentioned Medicaid. We're supposed to be a panel on the private market, employer-sponsored insurance, but how does Medicaid, how does Medicare, how does the self-insured, I guess it says self-insured as well, but how does Medicaid, Medicare, those other markets, cost shifting from those programs, uncertainty in the marketplace, how does that impact your employer-sponsored market and coverage? What are you seeing?
It impacts it in a big way. That is why we're seeing those rates. And I like to remind people, as the commercial payers, we have to care just as much as what's going on in Medicaid as Medicare as what's going on in our market. If Medicaid has rates that are way out of whack, we're going to see it on our end because the providers are going to try to cost shift. Now, something the Division of Insurance has been grappling with is most people, they're paying outright for our insurance. It's not backed by an employer, helping to pay for it. It's not paid by the feds where Medicare is. But if we, how much can we bear that cost shifting? So much so that we worked with our partners at Medicaid, sitting in the front row, and the Division of Insurance gave them $5 million in the budget for FY 2024 to do their Medicaid rate study. Because we said we need to be part of this solution so our rates can stabilize. And we're looking at what can we do collectively as the state to influence Medicare. Does it mean doing something innovative? I'm thrilled we have Dr. Quinn leading the way with an ACO. We need to pay more attention. We need to see how can the state be involved in that and stabilization, because then we'll see it in our markets.
Just a quick follow-up. What would something innovative look like to you?
There's going to be lots of options. I could talk about this all day long, but I think value-based payments and value-based care and looking at how can we blend payers together. We've heard whispers of CMS possibly coming out with new rounds of innovative payment, and Alaska needs to be ready to jump on that, especially with Medicare. I think it's the only way we're going to make a difference for our senior population and increase access.
Gary or Pat, you want to take the how do the other markets impact you?
No. We're certainly aware that there's cost shifting. I was aware of that when I was on the labor management committees, and our consultants would always point to how much choice in your plan design would incent people to shift out to another employer. For example, education employers in the state of Alaska are probably the last ones to see the $100 deductible go bye-bye. And as a result, many people shifted to those. Well, from what we can read in the news around the state, that's no longer the case. Education, both higher ed and K-12 are seeing some of those effects of cost shifting not only historically to their plans, but in the greater market for Medicare and Medicaid.
It's always a concern for us and it dovetails with something you raised in your opening, in your introduction, the extension of the enhanced premium tax credits. So most states are dealing with really significant Medicaid tax cuts. Thankfully, Alaska's not in that boat. But we will be dealing with a lot of uncompensated care if our fears come true and they don't extend those tax credits, and people wind up having to fall off the rolls for one reason or another, and that will increase that'll worsen the balance sheets at hospitals, and hospitals reasonably come to commercial carriers to plug the holes in their buckets, if you will, and so that inevitably leads to increasing the cost of insurance for all Alaskans. And so it's important for all of us, and this conference has been really encouraging to me because, you know, I had a few ideas about things that we could innovate and advance and help further address underlying costs in the system that we could help enhance affordability, right? But I've heard a lot of others here, and so I'm really kind of heartened as I come out of this.
All right, let's switch to prior authorization. I know there was a recent prior authorization reform in Alaska. I'm going to start with Heather on this one. How do you see that impacting the markets you oversee? What's exciting about it, and what do you expect to get out of that reform?
What's exciting about it is how we came about with this policy. Oh man, we really blew prior authorization in 2024 session, and it blew up bad. So we took that. We had a couple of legislators come to former Director Wing Hire and say, okay, I need the division to put some time and thought into this. But who really led the way was the Hospital Association. I'm not sure if Jared's still sitting out there somewhere, but Jared, and working with Bruce Richards at the Central Peninsula Hospital, put a roadmap, put pen to paper on what can this policy look like, where everybody gets a win and nobody is really the one who's going to lose. Nobody got everything, but everybody got something. And they sent us their version. We looked at it, said, okay, we need to make it comply with Title 21. We were the brokers to coordinate with the insurers. AHA was the broker to coordinate with the rest of the providers. We came into the legislature, and I remember we were meeting with Representative Mina, and we're like, we have a solution. And it was just shocking to legislators that we didn't have a fight. That legislation passed all in one session unanimously. And we did a delayed effective date till 2027 to make sure our insurers are ready with their systems, because all that takes time, that we can get regulations in place, which, as you know, is not a fast process. So it's exciting. We also found solutions. So we all have a prior authorization story, right? How it's been failing. But if you have been on a medicine forever that works, and you have to switch your insurance during open enrollment, you shouldn't have to start back at the beginning and go through all of the step therapy. So we addressed that. We addressed when there's cancer situations. We also didn't get rid of prior authorization because it is a legitimate tool. So I think it really has that everybody can get something. And I know the Hospital Association is holding it up nationally as a solution. I got to brag about it with my peers at our summer national meeting. So I feel like there's hope. We can come together and fix that, and I hope the other payers take that solution from us.
I spent a lot of quality time with Jared this fall and winter, and I would agree they are due a lot of credit, and he himself, I really came to appreciate the quality of his character, and kudos also to the department for sort of shepherding us and making sure that when the cat stayed in the pen, if you will, and our vision is that prior auth would become as invisible as possible. That in most cases, you'll have your prior auth before, this is vision, right? You'll have your prior auth before you leave your doctor's office. And this actually happened to me once. I was visiting with my primary care physician, and we were talking about a medication, its use would be on the edge of its label, and so he asked me a couple questions that he knew that Primera would want to know in their prior auth, and okay, blood pressure, blah, 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 check, and sure enough, approval before I left the office, and that's how it should work. We just sort of a level set, we prior auth 2% of our claims. Other carriers are much more aggressive about it, I'll just say that. But, and we're continuously tweaking which 2% we do, and the underlying incentives built into the bill are to drive more and more and more physicians to adopt electronic workflows and interact with our system that way and electronically, because still today there's a lot of prior auths that are initiated with a fax, and that vision just can't happen when that is started that way, because that necessitates a manual process. So anyway, I think I'm encouraged about it. I think it'll ease the administrative burden in every provider's office that adopts it, and I think it'll make healthcare work better, which is one of our aims.
I'll second the kudos for Jared and the division and this extraordinary thing that happened when everybody got into a room and said, okay, we can make this work. And I'll also second the hatred for fax machines. We've all seen the movie where the aliens attack and the fax rolls under the desk somewhere. And that literally was happening and the cause of a lot of the consternation. So well done. And I can say that in the self-funded side of the market, that are our folks that we talk to, we benefit from those kinds of improvements in the market writ large, and we're always happy to see that.
All right, we're gonna do PBMs next. What's their role in your employer-sponsored and self-funded insurance market? How do you make them better? Heather, we're gonna start with you again because you're closest.
Oh, PBMs. Always a hot topic. So I think I'll let Pat take a lot about PBMs, but I will say what the Division of Insurance is doing, because most people may not know. We are now regulating, and we have been the regulator of PBMs for years. Senator Giesel led that charge to make sure there was more oversight. We've learned a lot. PBMs are difficult. So the last couple of years, the legislature has made some policy calls asking the Division of Insurance to increase our oversight over PBMs. Since I've been on the job for 2 years, we went to, okay, we're going to register PBMs separately. Went back and realized, nope, that's not going to get us there. So this last year, what went in our omnibus bill, we are actually going to license PBMs and license third-party administrators. And I'd say we are doing that because we learned a lot. We're trying to shore up our foundation and make sure we can do market conducts on these companies, we can take consumer complaints and grievances and really have that consumer protection, which is what the DOI's mission is. So that being said, we're figuring this out. No state, we're all figuring it out together. Nobody has the perfect solution, and we desperately need the federal government to do something. So that way there's set rules. And it gets difficult because we're regulating, and they all have to, now be licensed with us. But when I'm taking complaints, it's only if they're my payers. I can't take a complaint about Pacific Health Coalition's PBM or Aetna, CVS, any of them, unless they're in my 15% of the market. So we're still figuring that out and how best. I don't think they're all evil all the time. They're trying to do good work, but we needed to put some structure around it to make sure there's consumer protections. And I think that's a great role for the DOI to be in.
The Pacific Health Coalition has as one of our contract options that self-funded plans can take advantage of a purchasing solution. It is not a PBM, but it is directed to contract with a PBM, currently CVS. But that slice that we have between the consumer and the PBM has proved most valuable in that it negotiates some of the best rates available in the market today, and then turns around and refunds 100% of any rebates or other incentives that the manufacturers may make available. And it's audited every year, and we go out to bid to see which PBM wants all of this business, and it's been a very, very effective model. Where we run into trouble is in market strife. My own grandfather used to own Phillips Pharmacy on the corner of 12th and Cushman in Fairbanks. There's now a State Farm insurance agency there. And the business has changed materially from that day, certainly. But there are market pressures out there in the world that are not going to be solved by legislation that requires certain kinds of reimbursement rates. And that has been a problem for us in the past. And we already make accommodation for those areas where there are only one local pharmacy. But when I was Division of Insurance, or a Division of Retirement and Benefits, sorry about that, back in the day, we had a small community that had 2 pharmacies, and the pharmacist called and said, "You need to pay me more." And we said, you know, the outfit down the street decided they liked our contract, and we gave them a little boost compared to urban areas, and they're happy with that. Click. A week later, "You need to deal with me and you need to pay me more." I thought we had this chat. Well, I bought the other guy, and now I'm the only one in this community. So there are strong forces at work that are not necessarily always focused at the consumer. Sometimes they're focused on the middle layer. And we want to be sensitive to those, but we also want to congratulate the division and folks arriving at reasonable legislation to license those so that there can be some oversight and transparency.
This is always a fun topic. PBMs, well, level setting again, Premera is one of an increasingly fewer number of health carriers that isn't owned by a PBM or doesn't own a PBM. We are consumers of their services on behalf of our members is kind of the way we look at it. And so, you know, supervision of these healthcare benefit managers, if you will, is, I think, important to us, as well as transparency. And we think that the role of a PBM is really important. There have been just innumerable examples of, well, call it what it is, gouging of prices at the pharmaceutical manufacturer level. And you know, I'm sure all of you, like me, are thinking of those examples right now. And so what the PBM can do better than what we can do as a company is pool our nationwide. We have 2.1 million belly buttons that we look after. So they pool those 2.1 million with several other million members from other reasonably and some large health carriers. And then they negotiate with that PBM, with that manufacturer rather, for that drug. And they do better than even the state of California could. Because of California's size, they're just not, California's not as big as the number of lives represented by these PBMs in some cases. And so they get huge, their profits have been massive in past years. That's much less true nowadays. But I think, you know, the supervision, the transparency, and continued attention to it on all of our parts is, I think, really important.
All right. What is the next kind of big innovation or small innovation to promote, you know, cost containment, lowering costs, increasing quality in the employer sponsored insurance market and self-insured insurance market? I'm going to start with Pat on this one.
This is fun. My predecessor toured a near-site clinic in another state and came back really enthused about what was possible if the self-funded coalition decided to operate its own clinics in a particular area. The first step, of course, is to approach local clinics and say, can you meet us at this model? Here's the pricing we're thinking of. And those were unthinkable thoughts back then. And so the coalition opened a clinic in Anchorage, hired an operator who hired doctors, nurses, physicians' assistants, and equipped itself to do x-rays and simple procedures on site. And it's been very, very popular. I think I shared earlier an example where one of the member plans can send somebody to our clinic and they can get an x-ray and be charged $75. That's the film taken, or the image taken and read and interpreted. And then they know if they need to be referred to a specialist or not. So we've begun to expand those, and now there's one in Fairbanks and one opened in the Mat-Su just recently. But we think that that wholly owned coalition, nonprofit clinic model, where they can also obtain certain pharmacy products on site before they go home, has been wildly popular. And we look forward to expanding the number of folks that can gain access to that.
That's pretty exciting. We'll have to talk. We're really focused right now on primary care. And so some of the conversations that have been held today have been exciting to us as well. And just a data point. The cost of care for people that have a relationship with their primary care physician is 27% lower than those that do not. It's remarkable. Is it because they're healthier people? Probably not. I think it's because they're catching things early. And so thereby alleviating a lot of expensive services down the road. So there's a lot to that. We've in Washington State, we've initiated, I think we've got about 15 different Kinwell clinics, we call them, where they're direct primary care for Primera members, similar to what you described about yours are interesting in that they're more diverse than the services they can provide. We're strictly primary care, but we'd like to roll that out up in Alaska too, and we've had challenges getting that going up here though. But it's on our list. Okay.
This is a loaded question, right? I probably have more ideas for innovation and change than we can possibly do, but I think we're aligned to actually do something big. We heard about it during the lunch panel, utilizing the Rural Healthcare Transformation Fund. The Division of Insurance and the Department of Health have been trying to make sure our work is coordinated and running in parallel the last couple of years. That includes the work DOI is spending, focusing on primary care. We spent a lot of 2024 going out and talking to providers. No agenda, just tell us what we need to fix in primary care. And we took our friends from Medicaid with us so they could hear the same thing at the same time. And we learned a lot. And I think we have to continue to sit down and talk to the providers. We take our ideas and say, okay, will this work? Because they're the ones that are gonna have to do it. We can have every idea that we think is great, but if we don't have a provider who's willing to work with us, we're not gonna be successful. But the division, we had a primary care RFP. We pulled it back with all of the fun federal changes this summer. We're gonna beef that up to make sure we're addressing those changes and put that back out on the street, where we can really look at what is driving the cost in primary care and how can we increase that. One thing we heard talking to providers that I really wanna find a way to address is how do we reimburse for case management or community health workers in the commercial space. Medicaid looks at that, and we do it in behavioral health, or we're looking at using community health workers. But we need the doctor to be working at the top of their licensure. They don't need to be spending the time literally sitting on hold to get their prior authorization, whether it's the commercial market, Medicaid, whatever, because that all adds to the cost of care. We don't need a social worker necessarily doing that. So how do we have somebody who can just help connect the person, make sure they're taking their meds, they have a way to get home? Because that's not just a Medicaid problem, that's a commercial healthcare problem, that's a Medicare problem. Dealing with those complex things, life is messy. I know we all have those stories about, oh my gosh, this friend is trying to figure it out. I have a professional friend who, reached out last year, one of the smartest women I know, and is like, it shouldn't be this hard to coordinate care for my aging parent. Why is the system so fragmented? So even those of us in the commercial space still need to have space for that. And that's my big dream. How do we reimburse that?
I'm looking at the clock. We're going to leave some time for questions, but I'm going to ask at least one more here. And this kind of dovetails on some of the other things we've already talked about. But I want to talk about employers in buying insurance or providing insurance to their employees and their insurance partners, looking at being the best consumers of healthcare. I know we've already talked about the clinic model, but what are other options, what are other opportunities for employers and their health insurance partners to engage in the consumption of healthcare and promote quality, promote decreasing cost? What are you guys seeing? What are you excited about in that area? I'm going to start with Gary this time.
So low-hanging fruit on this one for employers is just coach your employees to get that relationship with that primary care physician so that employee future-wise is less costly to the employer. That's pretty easy. And so I think that's a simple one.
I'll second that. It's very effective. Particularly the coalition, one of the things, the secret sauce we call it, is the relationship between the employer and the employee group. They maintain their unique identity, and we've been invited to talk at teacher in-service events where we talk about the coalition and the importance of taking advantage of all the benefits they have.
So I'm going to go a little different direction. I don't disagree with what they said. I think we need basic consumer healthcare literacy. We take consumer complaints at DOI. You're an individual, you gather up all of your information, you send it to us. You have a Blue Cross plan. You figure a Blue Cross plan is a Blue Cross plan is a Blue Cross plan. But it's not. You send it to DOI, we ask you who pays for that. They don't know, or it's not ours, 15% of the market. And then we have to help them and try to do a warm handoff if we have that connection. We're fragmented, and consumers don't know that. So I think as employers and employees, we have to figure out how do we teach people how to access their health care. Do you know what your deductible is? Do you know what a deductible even means? What's your copay? Do you know how to shop for an in-network provider? Because you're going to get the best bang for your buck when you're seeing an in-network provider where you know exactly what your deductible and copay are and you cannot be balance billed. But I don't think consumers in Alaska and employees really know how all that works.
All right, last one before we turn it over to the audience. And so I don't know if are the things still out there? Just start thinking of your questions. All right, we've got somebody with a mic here. So if you have questions, just flag our State of Reform colleague down, and she'll bring the mic. Last question while we're checking the audience here. Just final thoughts. What's your next big thing? What's the next big thing? And I know we kind of already talked about this, but just summarize it. What's next to make this better? What's your next prior authorization kind of win that's not prior authorization? I'm going to start with Heather.
I think it's coordinating with all of you. In particular, DOI is working very closely. I keep looking at my friends right here with Department of Health. We have to take this opportunity with the Rural Healthcare Transformation Fund and looking at, for us separately, primary care, making sure we're not going to miss this opportunity. This is an opportunity to finally do what we've all been talking about for years. It may not look how we thought it was going to, but we need to take this opportunity we have in this environment and do something big with it.
Got that devilish grin over there. So the next big thing is the thing that we've been working on most of this year, but we're still working on it through the end of this year. We'll keep working on it, and that is extending the enhanced premium tax credits. You may have seen ads by the Keep Americans Covered Coalition running here in Alaska throughout the summer and a little bit in the springtime. We're part of that coalition because we see it impacting Alaskans and making healthcare accessible to people to whom it would otherwise be just impossible. So that's the thing happening right now that we're working on for the next couple of months. I'm a little discouraged about it right now. I would peg the odds at single digits of success. We do have some really effective lawmakers in our corner, though. Our own Lisa Murkowski she was the first Republican senator to come out in favor of extending those tax credits. And for that, I'm eternally grateful to her, and I think each of us should be, and for her excellent service. So that's my thing.
For us, looking forward, all of our contracts are tiers. And the more people that are in the coalition and taking advantage of a particular contract, the lower the price is for everyone. And so we'd like to see more self-funded plans join. And we're constantly talking to those folks, hoping they see the light.
Sorry.
Well, I do have a question, and it's for Heather, or you, Gary, at Blue Cross. Can you tell us a little bit more about the extended tax credits and how many people it would affect if it expires, and a little bit more?
Absolutely. So the enhanced premium tax credits went into effect 2021, somewhere during COVID. And it impacts everybody on the individual market. The original tax credits had, their tiers of what was covered, and anybody over 400% of the federal poverty level didn't qualify for tax credits. But everybody with enhanced tax credits paid less. So what this means with them going away and rolling back to the original tax credits is, even though Alaska is in a much better position than other states, our rates are stable for calendar year 2026. Everybody on the market is going to pay more for their premium. And quite frankly, some are not going to be able to afford it. We're going to go back to anybody over 400% of the federal poverty level, which sounds like a lot, is not. It's like, I think for a single person is $78,000 in Alaska. It's not a lot of money, and that's gonna likely double their premiums. So we're gonna see, right now we have a little over 26,000, I believe, on the exchange. I don't know what that's gonna look like. The other thing of where that plays into for Alaska, I don't know how that's gonna impact our reinsurance program. And this is not new information. Former Director Wing Hire shared all of this information during the legislative session, but our reinsurance pass-through is funded by tax credit savings. If there's less overall tax credits, there's less overall funding that comes to the state for reinsurance. So we kind of get dinged on the front end and the back end. And so that's what we're trying to figure out and just share, what does that look like? Because we really don't know.
I have a follow-up just for people in the room. Do you have, so when you say, what would somebody, the person you were just talking about, when you say they would pay double, we're talking $500 more a month, what's the dollar amount?
And there are some public documents that we shared during legislative session that are still decent estimates. They could have been paying nothing, and they're gonna go to paying maybe $500. We could see, a family of four pay $2,500 out of pocket a month. And so that's a lot in a family budget. I mean, that's my mortgage. I can't come up with another mortgage payment. So, I mean, that's just facts. And this is not a decision that the state can make. This is this is at the federal level, it's Congress, and if they're gonna choose, and these aren't easy decisions. These enhanced tax credits were never meant to be permanent. So that's the position that Congress is grappling with, because it is a lot of money. So it's more money to the federal debt. So I'm not saying it's an easy no-brainer, extend them, but it is gonna impact Alaskans accessing healthcare.
Just on the expiration of the enhanced tax credits, and I think Gary mentioned this earlier, you would expect some people just not to take coverage up. And what happens to those people? How do they get care after that?
Well, I'm told that when things get bad for them, they show up at the emergency room, and that is very expensive, uncompensated care, right? And adds a lot of cost to the system that could have otherwise been avoided.
I think, yeah, the other thing I would add is we will have individuals, there's always that benefit cliff when you're leaving Medicaid and moving to the individual market, but I think we're gonna see people choose not to take that next job, not to take that next whatever, so they can stay covered. Or, I mean, I already have friends who I think should be buying insurance, but they're like, it's too expensive. So we're gonna just see more risky decisions. And as you know, Alaska has some pretty fun lifestyles that are not without risk. So it's not only uncompensated care, it's that aftercare. What does that look like? And we quite frankly, we just don't know.